next talk is going to be about long-term rehabilitation, outcomes and management of secondary consequences. And Dr. Srinivasan from our Children's House at Children's Health Dallas in Texas is going to be our speaker. Dr. Srinivasan had her Bachelor of Medicine and Surgery, including her internship at the Bangalore Medical College in India, and she did her pediatric rehabilitation residency and internship rehabilitation at Medical College of Ohio in Toledo. She is currently Associate Professor of Physical Medicine and Rehabilitation at UT Southwestern in Dallas. Thank you so very much for joining us, Dr. Srinivasan.
Thank you, Dr. Sarasky, for having me. It's an honor to be here. Give me just a minute. Let me see if we can get this going. Okay, here we go. Can you guys see my slides?
Yes.
Okay, perfect. So the AFM group is obviously done yeoman's work, and a lot of information is obviously being disseminated through this. So I would like to take a moment to thank them for their service. So we've heard about acute rehabilitation, about the management of rehabilitation in the first year, about the respiratory management, and updates from CDC, of course. And now is the time for long-term rehabilitation. So just briefly to mention, I have two children that I had talked about with my presentation, but I'm going to make sure that I don't go over time, so I'm not going to belabor the point. So the first child was 5 years old when he presented in July of 2016, and eventually was diagnosed with having AFM. He was treated with 5 rounds of IVIG and Flex, and then ended up with a tracheostomy and G-tube placement, and then came to us for inpatient rehabilitation, where he stayed with us from August of 2016 to February of 2017. So he stayed with us for a long time. And at the time of discharge from inpatient rehabilitation, he was able to take a few steps with maximal assistance, and then he continued to have drooling, was still on the ventilator, but able to tolerate his Passimir valve and some recovery in the left arm. So this is the patient. And then the other young man was 11 years old when he presented to the emergency department in 2018, and of course was also eventually diagnosed with having AFM. This is after his initial rehabilitation when he went home. I'm going to speed this up so that we don't spend too much time on this. And then this is, again, with him walking with his left-hand crutches. Again, I'm going to speed this up. So chronic functional problems that can occur after AFM are all related to muscle weakness that these patients tend to have. So we can have joint subluxation, they can present with scoliosis, with fatigue, with pain, contractures, limb discrepancies, and of course, the other that are not there are bowel and bladder impairments as well. So as we've heard, neurologic recovery is, we tend to see the distal recovery occurs more than the proximal muscles. Obviously, proximal muscles are more involved, which typically leads to a crawling kind of movement pattern that is seen in the acute rehab, of course. And other things to remember are the most profoundly affected muscles are the least likely to recover. And then at 1 year of age, after the event, there's like 75% to 90% residual weakness, with, again, recovery is seen rapidly more in the first several months. They tend to make functional gains despite muscle weakness and develop compensatory strategies. Now, obviously, the whole goal of rehabilitation is to ensure that the compensatory strategies that they develop are not harmful to them, i.e., they are not putting any undue stressors on their joints. So long-term rehabilitation. And then outpatient management obviously is continuing with the outpatient therapy, depending on what they require, i.e. do they require physical therapy, do they require occupational therapy or speech therapy? These should be provided. And then we also do episodic inpatient rehabilitation admissions based on the specific goals that the therapists and the patient families come up with. And what we do at our hospital is based on the Kelly-Krieger model, which we're very thankful for having shared with us. Janet already talked about nerve transfer surgeries at 6 months after diagnosis, and then management of bladder and bowel issues. So with bladder involvement, there's a sensation to urinate, but there can be difficulty with bladder contraction to release the urine. Hence, these patients may end up needing intermittent catheterizations, clean intermittent catheterizations, and to manage their bladder function to ensure that they don't develop any urinary tract infections or don't develop any kidney stones or kidney involvement. And a referral to a urologist is very important. And with the bowel function, because of the immobility, they tend to develop constipation. And they would require a high fiber diet, adequate fluid, and medications like stool softeners and suppositories as needed. Janet also mentioned about osteopenia/osteoporosis. In our setup, we have endocrinology and nephrology who manage these conditions, but we are obviously keeping track of these patients to ensure that these conditions are not occurring, or if it's occurring, we ensure that they are being referred to adequate specialists as quickly as possible. And then we also refer to orthopedics depending on the complications that arise. And we encourage full therapy and hippotherapy as well. And then continuing ongoing NMES home exercise program or the home FES program. And then ongoing psychosocial support, counseling, or psychiatry are also key for continued management. The patients tend to have, they are at risk for subluxation, hip subluxation, shoulder subluxation, and limb-length discrepancies. They can develop joint contractures either in the shoulder, hips, knees, and ankles. There's development of scoliosis. Orthopedic referral should be placed earlier rather than later. 33% of patients with AFM have scoliosis, and research studies have shown that patients who presented with ventilator dependency at the initial AFM presentation and had more number of limbs involved had a lower muscle strength score and had decreased ambulation. These patients were more at risk for scoliosis. And then the PAM score also that was developed by KKI, also when that is low, then is at increased risk for scoliosis. And then, of course, 20% of patients with AFM have long-term respiratory issues. Limb-length discrepancy in the upper limb can be seen in about 21% of patients, and in the lower limbs in 28%. And scoliosis, depending on the study, was between 35 to 58%. And then pain was seen in 29 to 40%, and then or 61% depending on the study. 39% of the patients at discharge had pain, but in follow-up, it was not seen as commonly. And then other factors that result because of the muscle weakness are fatigue, contractures, and joint subluxation. So typical equipment and braces that are used in the rehabilitation, as Janet mentioned, standards, wheelchairs, and walkers. And obviously, the positioning in the wheelchair is important. from a point of building endurance and then appropriate back support. Also helpful for respiratory and a GI standpoint. So the wheelchair, obviously you want to ensure that they are sitting at 90 degrees. And then sometimes the wheelchair is placed in a lordotic position to decrease, to help decrease the scoliosis progression. And body weight supported treadmill training or ambulation with support is also continued usage is important. And then orthotics and braces, depending on involvement, either AFOs can be used, or sometimes a thoracolumbar sacral orthosis, a TLSO, to help with positioning in a chair. And then hand braces, which could be either resting hand splints or benic splints. So this is just a functional electrical stimulation bike, which I'm sure most of the AFM community is very familiar with. And this is the Locomat, which can be utilized even in the outpatient long-term management, depending on where the patients are. I live in Texas, so obviously things are very spread out here. And some of the patients may have access to these and some don't, but in a home SES bike, a lot of my patients have been getting those. School transition is important in an acute setting and also in an ongoing follow-up in a clinic setting as well. So this obviously is based on the physical and cognitive level of the patient. So if they are medically complex, they may need homebound schooling with graduated return to school. And then obviously they'll need accommodations at school, including shortened days, help with the homework, instructions, and then the logistics of carrying the books, and then help with taking tests. And then if they are continuing to be on a ventilator or they have a trach, then they may need nursing support at school, and then feeding support if on G-tube feed. And then obviously it's important to have a team leader in charge, because you're going to be doing problem solving as the issues arise. And this is usually either a neurologist or a physical medicine and rehabilitation specialist, just to reach out to different specialties, i.e. orthopedics or gastroenterology or urology, neurology, as the case may be. And a lot of these Janet covered earlier on. And then the other thing is class accommodations may be necessary for physical education. Class accommodations will be necessary, and then assistive technology will be needed with PTOT evaluation in schools. And then obviously the needs of the students will be individualized after assessment. These are just a few of the service eligibility categories for special education that children can avail of depending on what the needs are. So our first patient, he underwent a nerve transfer, and then he regained a fair amount of function in his right hand in September of 2017. And then he did his second round of rehabilitation at KKI in 2018, and then came back to us in 2019 after his nerve decompression in 2019. And he eventually has been decannulated. He has some swallow function. He continues to use the G-tube for his feeding purposes. He's able to ambulate short distances at home and continues with extensive therapies at home. And the older patient, who is now 15 years old, he underwent bilateral lower extremity nerve transfers in October 2019. And currently he is doing home health physical therapy. He attends the neuro gym 1 to 2 times a week, does physical training 1 time a week, and then uses the new VE stim therapy. Obviously, this child is doing a lot of therapies in addition to doing his school work, and he's in advanced classes at school as well. And he also has a home FES site. He was doing it more frequently before. Obviously, this varies now between 1 to 2 times per week. Physical therapy has also added dry needling with electrical stimulation and is apparently noting activation of new muscle groups. This was something that I learned from the patients, obviously. I have not seen a whole lot of dry needling being used for this particular condition. And he's currently able to ambulate with a single lock strength crutch. This is also, this was actually last year, and he has progressed to using a single sorry, I'm trying to speed this up. Okay, there we go. And from this, he is now ambulating with a single crutch. So this is our therapy protocol for AFM at our hospital. And when I say, episodic care, it is more along the lines of they've done their initial inpatient rehabilitation admission, they go home, and then come back with new goals, either after their nerve transplant or depending on where they are in Texas, as they're very spread out. If they do not have adequate therapies in and around their homes, then we admit them back for either inpatient or day program. And that's basically all that I have. Thank you very much.
Thank you, Dr. Srinivasan. So while people are going to put, if there are any other questions, there are some questions that we have from previous that you might be able to help. First of all, there was a previous question about any resources for adolescents and young adults. And I know that from my point of view, there are no specific resources that I'm aware of for adolescents and young adults because, because more younger children have been affected. I do think that we can use the spinal muscular atrophy type of resources, and I'm not 100% sure that I'm addressing the question because the specificity of resources was not made clear. But the SMA type of resources could be helpful.
I mean, with my experience, we've had like 2 adolescents who had AFM, and I think they basically reached out to, I want to say the PVA, since it's like SCI. So I would say PVA, one of the patients reached out to PVA, and in fact, it was interesting as to how she found it all by herself, which was educational to me. But she had issues with bowel and bladder management, and we were teaching her everything. And of course, as we were teaching her about the bowel and bladder issues, she found PVA online, and then she reached out to them. So I would say that may be one option. And then, like you said, SMA would be one, the SMA site. And of course, I don't know how much the acute flaccid myelitis website has for adolescents. I didn't find a whole lot there, but
and then,
those are what I would have.
Yeah, probably SRNA, the single rare neuroimmune disease, is going to be the go-to for almost anything that's related to this. Okay, Dr. Pardo is asking very general question. What are the virtual and telemedicine resources available to AFM families? Do you offer virtual and telemedicine resources for AFM families? Services?
Yes, absolutely. Yes. We can do virtual doctor visits with the neurology and PM&R as well. And I'm not sure if that's what they're asking, or are they asking for therapies?
Well, just general resources available for AFM families that are, I guess Carlos can jump in if there is more specificity to it. But your answer is yes. I know that here at Kennedy Krieger, we do have a limitation in delivering out of state virtual care, which especially physician care. Now that the emergency state has been removed. So Dr. Helfrich from Netherlands is asking, so he asked during Dr. Malacosta's talk, but she had to go. So maybe you can jump in with an answer. Maybe I can help too. Do you see improvements of respiratory function even years after onset of weakness? Do you think active respiratory rehabilitation may still help in late phases?
I guess it depends on what you call late phase, but the one of the children that I talked about, he was diagnosed in 2016 and had his tracheostomy placed then and was on the ventilator as well. He finally got decannulated in 2019. So that's like a 3-year gap. So I would say if you're able to provide that, I don't see any reason why that would not be beneficial, since the recovery is such a slow process.
And from my point of view, I know that I've been an active participant in the ultrasounds that Dr. Malacosta mentioned. And so I've been able to see the progression in time. And there is an increase, an improvement in diaphragmatic motion, although as Dr. Malacosta mentioned, it is not consistent. But if you look at 2 or 3 or 4 studies, we have a couple of patients that we've done this, we've seen progression on the ones that are actually using, that have a diaphragmatic pacer. We did not have the same experience with the ones that do not have, because they don't come for follow-up. And also one specific note that I need to do is that we looked at the electromyographic activity of the diaphragm post injury, and while you are on dependent on a ventilator, the diaphragm does not fire. It only fires once you decrease the ventilator support. So those are all just small amount of data that says that, yeah, you have to use it so not to lose it.
Right.
Is there a correlation with the need for ventilation during AFM and the severity of the preceding EVD68 respiratory infection? And I'm going to say, Dr. Pardo, I'm going to let you answer on that one, because I can tell you that I don't have an answer for that.
I don't think that there is an answer for that. And in the experience that we have here at Hopkins, we basically we found that patients only have a quite significant amount of respiratory symptoms, particularly with secretions and respiratory difficulties. So we may need to have more prospective studies in the future for answering that question, because we, unfortunately, with the anecdotal experience that we had, I don't believe we are able to answer that question precisely. I mean, it's very clear that the patients that were admitted in 2014, 16, and mostly in the 18 here, I mean, many of them have a quite significant amount of respiratory problems associated with the infection.
Do you have an impression of how long the TLSO? You mentioned the TLSO should be worn in children with scoliosis, and thank you for introducing, because part of the information that you presented about the likelihood of developing scoliosis is from Hopkins, and Dr. Sponsello probably will talk about that. But can you talk about the length of TLSO wear? We know that from spinal cord injury, from pediatric scoliosis, spinal cord injury, you need like 23 out of 24 hours wear for TLSO. Is that the same case for AFM? Or what is your opinion?
I would say it's probably going to be the same. It may be a little lesser, just depending on the amount of truncal support that they have, or truncal control they have.
Yes, and actually the paper that you quoted, the numbers there, mentions that children that did develop, children with AFM that did develop scoliosis, had more involvement on MRI of the thoracic spine. So it wasn't even the highest level. It wasn't the one that had necessarily cervical involvement with the traplegia. It was the ones that had more neurologic, more anterior horn involvement in the thoracic area.
Yeah.
Okay.
Yeah.
I did want to mention one thing. You mentioned nerve decompression versus nerve transfers. So decompression, as far as I know, and please correct me if I am wrong, involves only the lower limb. So we in the AFM community, no nerve has been decompressed in the upper limbs. Is that correct?
Correct. Yeah, you're right.
Okay. And there was one other, there was, I did want to mention the fact that currently we are conducting a prospective study in which we look at the role of transcutaneous spinal cord stimulation in children with pediatric traumatic and non-traumatic spinal cord injury. And we had one of the participants was one of the children with AFM, and he responded incredibly well. He had an incomplete, but he was ventilator dependent, incomplete injuries, and he responded extremely well to the transcutaneous spinal cord stimulation, which is one of the neuroplastic interventions that I am very excited about when we're talking about the spinal cord related disease paralysis. Talking about resources for children with AFM, there are 2 books that have been published specifically for children with AFM. These are for younger children. One of them is No Time for the Moon, and the other one is Alfredo's Magic Wand. So these are really, they are written by parents of children with AFM, and they address the paralysis at the level of a young child to allow for better understanding and reintegration. So No Time for the Moon and Alfredo's Magic Wand.